Neglected tropical diseases have always been causes for major disabilities, and my guest today, Dr. Asrat Mengiste, is one of the reconstructive surgeons at the forefront in helping address those diseases. Very warm welcome to the program, Dr. Asrat.
Thank you very much, Tafara, for having me.
So you largely deal with neglected tropical disease, is that correct?
Currently, mainly, yes.
So when you talk about these things, you are basically talking about podoconiosis. It's one of the tragically prevalent, if you will, across the country. Is that correct?
You're very right. Very right. So studies made in the past decade showed that over 1 million people are affected with this disease. It's called elephantiasis, actually. Most people understand it as elephantiasis, swelling of the lower extremity, legs. And it's a very disabling disease. And this disease has to do with exposure to red clay soil.
That's correct.
And it's prevalent in almost half of our regions. And 345 waradas are endemic for this disease. So what happens is, due to exposure to this red clay soil, particles go in the food and then destroy the lymphatic system, and the fluid flow upwards is disturbed, and this brings about swelling, which gradually increases, and then brings about all the disabilities and also changes in the leg.
So when you're saying over 1 million people are patients, literally, right? They are affected, correct?
They have leg swellings, which is
of various degrees,
disabling.
Of various degrees.
For various degrees. And, because of the lymphatic system, the defense mechanism of the leg is affected. These people are liable for frequent infections. And these infections lead to further narrowing of the lymphatic system, flow system, and it gets on worsening from time to time. And they become less and less active in work and more days in bed. And they really, most of them are not able really to function or work. They really stay at home more than 50% of their working capacity time and the like.
And there are very many who migrate to bigger cities, right?
Definitely.
Because of ostracism and all that stuff.
Exactly, because the stigma associated with this is very severe. First, they are not accepted in the community, and they are stigmatized, and also they have also problem with self-stigma. And because of this, they are also not included in the community. So most of them would like to really go out of the community and go to different cities and try to make a living, maybe begging or maybe other activities and the like.
And there are reports that 3 million more are at risk.
Well, when you say at risk, this disease occurs only if you have a long-term exposure with the red clay soil, and that
which many in the rural areas have.
That means you have. That means it's only those people who are not wearing shoes for many years, who have contact with the red clay soil directly, are affected. So all those people who are not wearing shoes in the rural areas, they are at risk. But not all are developing. But some who has some genetic predisposition to this disease develop this swelling. And fortunately enough, this disease is preventable just by wearing shoes. And that's it. So it's a disease of poverty. And also leading to poverty. All these people cannot work, and then so wearing shoes is given a great emphasis on this. And similar scenarios are happening also in other African countries. Like one Eastern African country have put into legislation that every citizen, especially children, is mandatory for them to wear shoes. So it's very preventable. But unfortunately, this disease was first published by a British missionary doctor who used to work in Alert Hospital, where I have been working. And 40 years ago, he published this. He realized that many patients are coming with this leg problem from areas of highlands, red clay soil, and the like. And then he realized also this connection of not wearing shoe with the disease. So he suggested that shoe wearing should be really addressed. This was 40 years ago. But his findings were put into the shelf for many years. And then it's only the last 2 decades that we again emphasized on this disease. And since 2013, it's recognized as a priority disease by the Ministry of Health, and activities are going. So, in summary, yes, there are people at risk, but as far as they are not wearing shoes.
So you think it is being mitigated now? As far as the cases are concerned, or there is some kind of resurgence, if you will?
Well, a lot of attempts are done to improve the behavior of our citizens in terms of shoe wearing. But it seems that, old habits die hard and not accepted universally. I'm really observing that still a lot of, especially in the rural area, members of our communities are still going barefoot. And this is not really only the Ministry of Health effort would really bring this. So we have to include this in the education curriculum, that shoe wearing is very important. There are some organizations who are organized shoe clubs in schools so that, the children can tell their parents the importance of shoe wearing. So this neglect has brought about also further neglect of this disease. So the way forward, if we just, prevention is more cheaper to address. And if we just work hard on shoe wearing culture, then I think we can eliminate this disease or control this disease in a decade or so.
That's good news. But when you're on the ground, what do you observe? Are people, these habits, they're not easy in dying, but do you see any glimmer of hope?
Well, there is progress based on evidence. So currently, according to the Ministry of Health data, in the rural areas, the shoe wearing habits is over 70%, because some studies have been done. So this figure was very disturbing some years ago, 10 years ago. So there is improvement based on that. So now the master plan of the neglected tropical disease is aiming to have 100% shoe wearing by 2025. So we are working on that, but still a lot needs to be done through the community level, and so this needs a multi-sectoral approach so that we can all together eliminate this disease.
Well, the other thing I want us to talk about is the cleft palate thing. Very serious also, right? There are diverse reasons for that, but it's quite prevalent across the country too, right?
Yes, it is. It's actually a worldwide phenomena. Cleft lip and cleft palate is a birth defect, one of the most commonest birth defects. And in Ethiopia, studies done show that about one child born out of 700 to 1,000 gets this disease. And the problem is that for so many years, surgical repair services have not been really put the demand, and therefore the backlog was very huge. So what we have done in Ethiopia is that in 2006-07, we initiated a very interesting program with the support of other organizations, reaching to address the backlog. And to date, for the last 15 years, close to 40,000 patients has been operated through this program, and they were getting free service. This has addressed somehow the backlog of it, because the evidence is that like 15 years ago, the mean age of the patients we operated were around 10 years. The average age was about 10 years, which is really disturbing, because this patient was supposed to be fixed by
much earlier.
They are 1 year.
Yeah, I know.
By 1 year, it would have been. So, but now, last year and previous year, according to the data we have, that average age has come to 1 to 2 years, which is very encouraging, which is a great progress on this. So the figure I gave you, close to 40,000 surgeries, is just done by the support of an organization which works with 30 partner hospitals in Ethiopia. So all these 30 hospitals are providing cleft surgery on regular basis. And I think the backlog is being addressed. Now we no more see more adult patients as such, and less and less of them are seen. So this is a good indication. But still, you can calculate how many newborns will appear with cleft lip, because this is birth defect, cleft lip and palate.
Do we have any inventory of sorts? I mean, at a health center level?
Now, having these 30 partner hospitals, one, and then also this service embedded in the regular surgical department and hospitals and the like. Training has been given also in the health centers, facilities, where every child born need to be really evaluated, and then this defect detected, and family members counseled for it, and then encouraged really to seek medical advice early enough, so that these children get the right service. So studies before have indicated that, as I mentioned, about 1 to 1,000 or 1 to 700 ratio are born with clefts, and we think that this will be a figure which we are going to have. We really know the population growth, we know the birth rate, we know how many newborn we are expecting next year, and we can calculate the number of clefts to be regularly having every year. So now we think with this, the level of capacity we have, I think not only addressing the backlog, but also addressing the new coming clefts, we will reach in a very short time period, so that demand and supply meet to address all these problems.
How do you access them in the first place?
Accessing one, as I mentioned, through the health system. Every child is entitled for checkup, and this is a very obvious defect.
But that's easier said than done.
Yes, this is. And then also this through the health system. The health system network, to the health extension workers and the like, the community is reached. 2. And 3, these 30 hospitals who are giving regular services, they are really good ambassadors for mobilizing patients, because all these patients who have gotten the service, when they go back, people now see the difference, and really will be very encouraged to take this patient to these hospitals. So by word of mouth and the like. And then also, even we are more aggressive in addressing this problem, because we also have some organizations, I know at least 2, who are actively mobilizing patients. They are going door to door in the rural areas and bringing patients. These are 2 organizations. And then again also, some of these partner hospitals have set aside pickup cars who whose function is to go village to village, really to look for these patients and bring them to the hospital so that they get service. So we have all sort of spectrum of, mobilizing patients, case finding and the like.
Interesting, but in the face of, again, stigma, how easy is it for you guys to be able to access those? I mean, parents would take this, for dispersed effect, as, for a curse. That's what it usually is in rural Ethiopia. That's how people perceive it.
It was, but, once they see that those children who are affected has been fixed and are transformed, every parent would be eager, anxious really to have the same kind of findings. And once, it's because of lack of knowledge that to start with, not many people used to know that this is a condition which could be supported through surgical repair and the like. Once they understand this, and they really see themselves that patients who have been operated before and have been transformed, then they are really jump and take these children to the health facilities. And that's why now we have evidence that the fact that the average age of the patients coming to the hospital is decreasing is indicating that more and more of the backlog has been cleared, more of those patients who have been neglected has been addressed.
Wow, interesting. So over the years, as you have said earlier, there is a local expertise, right?
Yes.
You've developed that cadre, if you will, of local physicians and surgeons who would be undertaking those procedures, right?
Yeah.
So yeah.
When we say like close to 40,000 patients have been operated within the last 15 years, the graph is going up very sharply. And I tell you, then when we started the program, there were a couple of experts and also a very handful number of surgeons who are doing that. But today we have close to 40 plastic reconstructive surgeons who are really actively engaged in this. So this is a great progress. And not only this, most of this has been trained also locally with a subspecialty program in Ethiopia. And currently we have 2 centers which are giving postgraduate training subspecialist surgeons on reconstructive surgery, which includes cleft lip, and this Addis Ababa University under the medical college, which is Yekati 12 and Alert Hospital. This is one of the universities. It has close to 40 students now who are on training and will be graduated within the coming years. And then also we have a second postgraduate training institute, college, Millennium Medical College at St. Paul's Hospital, which currently they have over 10 trainees. These are for super specialty in reconstructive surgery, and I think we are on the right track on that aspect. And the good thing is the newcomers, those trained, the young ones, are even doing much better than our previous surgeons. Oh, this is very encouraging. We are encouraged, and this makes me happy, actually.
Interesting. But that doesn't mean that you guys are not on the way out, correct?
Well, that's the trend. We do more and more on training, on supporting, rather than doing really the nitty-gritty things like, because we have really quite good cadre of staff doing these activities. And I tell you, when we started, there were only 2 centers who were doing this kind of surgery in Ethiopia. There are over 30 centers, and in the regions also distributed. So quite a big difference.
You've been recognized for years of work in the area by the Society of Plastic and Reconstructive Surgeons. It's quite a recognition of people like you who were invested in this intervention for so many years.
Thank you. Yes, the recognition is very encouraging. We have contributed a bit. So this is a teamwork, and so many individuals have really put their time, their energies, their resources to bring about this kind of change in Ethiopia. And I have really contributed a bit, I guess. And that recognition from the Plastic and Reconstructive Surgery Society of giving me the award of lifetime achievement really is very encouraging. But there are so many others who need also to be recognized.
That brings me to a very important component of this intervention. I mean, research. You have been doing, although you claim not to, you've been in the business, if you will, for many years, at least 20 years. Now you're also moving into research, and you and your colleagues have produced and continue to produce important. Can you brief us on that?
Yeah, thank you. Thank you, Tafara. Yes, research is very important. You know, all my career with my surgical expertise, I've worked with, to really alleviate some of disability issues. I have worked most of my career in disability-related matters, and with this elephantiasis thing is really very much worrying. And so for the last 3 years with Addis Ababa University, I'm based in Addis Ababa University, Tukurambasa Hospital. Now we are researching this elephantiasis issue, and the research we are performing is basically on integrating also other causes of elephantiasis, because there is also one caused by infection, which is brought about by mosquito bite and the like. 70 waradas are endemic for this, and it also causes this lymphedema thing, which is elephantiasis. So some areas are co-endemic for both diseases. And then also we have leprosy, which is really declining, coming down very much, but we have over 300,000 people who have been affected before, with some nerve damage to their legs, and they also develop some kind of leg swelling, leg problems. So our research was really, instead of treating this as disease entities separately, now we are working really as one entity with the common leg problem, and the treatment, most of the treatment for this are the same. So we have tested really to give treatment for the 3 disease entities in an integrated manner. And we have really showed that this is feasible and successful, one. And the second part of our study we have been doing is, you know, we have been really focusing most of the years on the physical aspect of these patients, and we are trying to alleviate that physical problem. But from the literature, we know that they are also affected in psychosocially, and some of them also have some kind of mental disorders. So in our research, we included this intervention also to address really the psychosocial support, the counseling aspect, and also those who with mental disorders are being also treated by those whom we train at the periphery within the health system. We have been researching within the health system, within the primary health system of Ethiopia, health centers and the like. And we have found that really this comprehensive kind of treatment has yielded much better results than just addressing physical.
So you've started to look at it from a packaged point of view.
Exactly.
Instead of a linear one.
Exactly. In a holistic manner, in a comprehensive manner. So the whole person treated, not just the leg or the foot or the like. So this has given us encouraging results, and integrating this also has shown that it's more cost effective and efficient for the work. So these findings would will be really evidence to scale up such activities within other areas of regions of Ethiopia.
Well, I think on that we have to end this discussion. Thank you very much indeed, Dr. Asrat. It was really a pleasure having you back on the show again.
Thank you, Tafara, for having me, and I'm very much delighted to take